Hello, everyone, and very good evening to you all. So this is Kapil Gautam signing as a host for the today's session. We are going to have talks on very special topic today. So I guess everyone is very excited for the topic. So I'd like to go through the introduction of today's topic and today our delegates speaker. So without being further delay, let's me go into it. And we are going to have a session on dealing with the ocular chemical injury. And as a speaking delegates, we have Dr. Surabhi Dutt. She is all the way from the India. So I'd like to go through the short introduction first. She had done her MBBS, MS, and fellowship from Dr. Shroff, fellowship in cornea from Dr. Shroff Charity Eye Hospital. She is an senior consultant, cornea and ocular surface specialist. So without, I can see your eagerness to study for the today topic. So without being further delay, I'd like to request Dr. Surabhi ma'am to begin the today's session. Over to you, ma'am. Ma'am, you are actually muted. You can unmute yourself.
Thank you so much. Thank you for inviting me, giving me the opportunity to speak. I just quickly share my slides. Is this seen? Visible?
Yes, ma'am, it's visible.
Okay, so I'll start from the first. So basically, this is a very important topic. It's very much not seen much because we don't know a lot about it. If we know about it, we can actually go into the depth, ask detailed history, because this is something which can be handled with every one of us as an eye care practitioners. So without further delay, I take up the topic and we could stop anytime if anyone has any questions. So this is ocular chemical injuries. I will be taking you through step by step how to take care of this condition, right from acute to chronic to how to deal with it. I have no financial interest in any way. So the ocular chemical injuries starts with the burns of considering any part, be it the lids, conjunctiva, cornea. It is a true ophthalmic emergency. And this is one of the most important ophthalmic emergencies where this needs to be taken into emergency and taken care immediately. So the ocular burns can be classified into chemical injuries and also the heat and the thermal burns, which we call it as radiant burns. The chemical injury can further be classified into acids and alkalis, which we would be taking into consideration in this meet. We will take care of the other things in the next following topics. The common alkali substance which we see around us, and the most common and the most severe, is lime. This is usually used in all the household construction work, and the other common one is the drain cleaners and also the over-the-counter sprays which we get for all the cleaning supplies. The acids, which is the most common, in the automobile batteries, vinegar, and the glass polish. In the third category, what we have is the irritants, which are easily seen all over the households. These are not very harmful, but they cause a lot of trouble to the patients. That's why they're called as irritants. So seeing all these factors, seeing the causes, we come to the point where what is the severity depending on? It depends upon the surface of contact. Suppose if the patient has only an exposure to the lids, the thing has fallen into the eye on the surface, but not inside the eye. So the surface of contact is minimal. Then you come to the depth. If it has gone inside the eye, how deep has it gone? Then you come to factors which depend upon the depth is the concentration, which means how strong or how weak it is, acids and alkalis, which I will come to, the time of contact between the chemical trauma and the time when you get the first aid given to the patient, and also the degree of the stem cell loss. Coming to the causes, we know now sources, most common and the most serious are the drain cleaners and the cement, acids, battery acids, and the bleach, which is the most common. Coming to the where we see and how they look. Alkalis are more severe. You can see that this is a cooked fish eye appearance. This penetrates very fast and it causes a lot of damage. Whereas acids, they are more safer. They They do penetrate, but they cause a sort of a thick layer, which acts like a barrier. Thus, they are not as severe as alkalis. Now, the pathophysiology I'd quickly go into, because as such, we all need to know what are we dealing with in the basic pathology. We have two parts where the hydroxyl is common between alkalis as well as the acids. So that causes a saponification, and that is what causes the thick layer. But in cases of alkali, we also have a cation part, which causes a lot of carboxyl group activities. And this leads to the penetration which goes into the tissues. Both the cell, both the cells which cause the fatty acid saponification and also the penetration together lead to the uh, proteolytic enzymes and also the ulcerations inside the eye. So the severity, as we know, we spoke, is depending on three factors which I believe we all should know as eye care practitioners: surface area of contact, the depth, and also the degree of stem cell loss. Common areas are cornea, conjunctiva, lens, and the uvea. Most serious complications are glaucoma, corneal melt, and also cataract. Coming to the structures one by one. In lids, we commonly see the edema of the lids, swelling, periorbital edemas, which we know about. Then you have also ulcers. These two are very common. Then you also have surface problems like all the other skin allergies, which we call it as dermatitis. Delayed effect of the lids, which is called as the chronic effects, are the cicatricial entropions and the ectropions. Now, conjunctiva, you have the congestion, ulcers, and the chemosis. Then in the chronic phase, you get the symblepharons, which you can see here, and you also have the pseudoteriogens. The cornea is the most common surface. So the conjunctiva and the cornea is the most commonly affected in a chemical injury. In cornea, you have the ischemia, you have the edema, and also the ulcers. In the chronic phase, you have the stem cell loss, and you also have melts. Uvea is rarely involved, but if it does, it causes a severe melt which happens and causes an atrophic pulpi. IOP can be raised in the chronic phase. In acute, it is definitely increased because of the inflammation which is ongoing. Now, coming to the various presentations, how an acute phase. When we call acute, we call it between the first 7 days of an alkali injury or an acid injury. So this is the first presentation which I have of a patient. This presents within the first 24 hours. You can see that this is very, it has a very stipple look, and it also has a severe blanching and chemosis and congestion. You also have this is within the next 48 to 72 hours, where you get a fish cooked eye appearance, which we had just spoken about, and you have less congestion, but you still have chemosis. And then you have this, which happens in the next 4 to 7 days, which is more of chemosis, which is also with a patchy chemostic patch and also a ground glass appearance. Now, coming to the chronic, how do they look? Any chemical injury, if not treated well enough, leads to these kind of pictures, which look scary, but this is a chronic phase which happens between 3 to 6 months. You get a total stem cell loss, and you get conjunctivization, and also you get a loss of any kind of contour or the integrity of the eyelids. Now, there is a very important classification which we all must know, which is being practiced everywhere all over the world. It is called as Dua's classification. In this, the grades 1 to 3 can be easily saved by just medical care. And that is why I say most of the patients come into this category. There are around 60% of the patients who can be saved just by medical care by all of us. We do not need to refer them anywhere. If you know this whole table, you would be able to take care of it. The only ones which require to be sent across for any further treatment is from grade 4 to 6. So what are these? When you see the eye, you have the corneal involvement, which is known as the limbus, and then you have the conjunctival involvement. So when you have clock hours, you have to depict them according to diagrams by clock hours. So when you have grade 1 to 3, it is anything which is involvement less than 6 clock hours, and the conjunctiva is less than 30 to 50%. But anything above that, which is guarded prognosis or poor prognosis, is anything beyond 6 clock hours, and beyond 50% of conjunctival involvement. I will come to various presentations so you will have a better understanding of this classification. So the management, you have to understand the goals and the management are the same for any chemical assault to the eye. You have to do a complete removal of the offending agent, promote the ocular surface healing, control the inflammation, prevent infection, and also control the intraocular pressures. Management can be divided into these phases. It is the immediate or the emergency treatment, then the acute phase, which is in the first 7 days, and the early reparative or the early phase, which is 7 to 21 days, and then the late is beyond 21 days. So if this is a very big point, the patient whose injured eye has not achieved an intact epithelium by the 21st day, then this is a risk for permanent visual loss. Otherwise, most of these eyes can be saved. So this is the first case which I would present is an 8-year-old male patient who came to the OPD with, we call chuna, which is also called as cement or lime. It had fallen into his right eye 2 days back. So remember, 2 days means it's still an emergency for us. But his history tells us that he did get an immediate eye care on the first 24 hours. That means he was given a thorough saline wash, which is important history for us. And also the other important history which we need to see and ask whether the other eye has been affected or not, whether the chuna or any other chemical has fallen into the other eye or not. Then we start the basic treatment. So I'll come to the treatment as I show you the pictures. Systemic was all right. So this is how the patient presented. He had a total, almost near total blanching. You can see that this is a total ischemia. This is a blanching which you see the whiteness. You have a stipple look and you have a ground glass hazy cornea. Now, this was also seen in the inferior bulbar conjunctiva as well as the fornix. So when we stained these pictures, I saw that this was a total epithelial defect, but the loss of cells was from somewhere 8 o'clock to almost going up to 1 o'clock of the cornea quadrants. So this is almost 270 degrees, 180 to 270 degrees. And there was a total staining of the inferior bulbar conjunctiva as well as the fornix. So this comes into the severe category, grade 5. So what did we do? We immediately, because we knew that it has been given a wash, but still when the patient comes to you, please again follow the norm of washing. Wash, wash, wash is the most important part in the acute phase. So when I everted, I saw that there were still chuna particles inside the fornicule of the superior fornix. We have to bit by bit take the patient into OT if you need to, or else whatever you can see on table, in the OPD, on the slit lamp, please do remove all of it. It's very important because any small particle will slowly keep causing a lot of inflammation inside the eye. Now, the most important is this, early effective irrigation. Very, very important slide. I want you all to remember that this is the most important part of any chemical injury management in acute phases. You need a drip set, saline, fluorescent staining, EDTA. Why do we need EDTA? Because it causes a pH balance. Because when you have an alkali, you have a very acidic also, you can have a lot of penetration. So you need to neutralize the pH into being balanced. Then you also have other things like glass rods. If you do not have any of that, that is sufficient if you have the first 6 points. So the goals are, you have to aim for epithelial healing, reconstruction. You have to aim to control the inflammation. And you also have to aim to prevent most of the complications. So the treatment, what we gave to the patient is immediate eye wash, EDTA, and also mechanical removal of all the particles. Now, reduce inflammation, we gave topical steroids intensively. That is because it's a grade 5. We gave it at hourly drops for the first 10 days. Then we also gave ascorbate drops, and you also gave oral vitamin C and also a cycloplegic. To promote the epithelialization, we gave the tablets, which again helps in promoting as well as reducing inflammation. We give preservative free. Remember, please give preservative free lubricants because they will have a lot of burning sensation. You cannot use PKC, BAK, any of these preservatives. Retinoic acid, if you do not have, it's all right, but at least please give something thick like sodium hyaluronate. Viscosity has to be maintained. Repair phase, repair and minimize ulceration by again the tablets. Most important tablet in this group is the tetracyclines. So you have to give doxycycline. But however, because if you have children below 10 years, it is very difficult to give them tetracyclines because it affects their dental growth. So you can give any of the other tetracyclines, but not doxycycline. And you also have to give a collagenase inhibitor. Topical is what we give 10 to 20% acetylcysteine. Management, what we did for this child, we took him up immediately after 24 hours. We planned it out. We took him for AMG, that is amniotic membrane grafting, plus a BCL under GA. So the first post-op day, this is how the patient presented. Obviously he's a child, he did not open fully. We had to pull and retract the lids. This is a complete amniotic membrane which we have placed. I had put 2 layers of amniotic membrane, so it was an inlay with an onlay, and we sutured it on various quadrants, various areas. It was also covering the fornicel areas. This is where we covered it even here. But however, it started to disintegrate immediately. And that's why we had to do again. We took him up again for an AMG. But this time we did a per string suturing so that there is no chance of the amniotic graft removing or displacing. We could see this is this slide shows that there has been a good uptake of the amniotic graft in the half of the quadrant of the cornea. This is at 3 weeks post-operative. The second case, which I would want to highlight, is about a child 5 years old with an injury with an incense stick. He was playing around, his parents were doing puja and they were praying, and he accidentally touched the incense stick and it went into his eye. Nobody saw this. The patient came to me after almost 6 days of having this injury. The child could not open the eye, and there was this huge scleral melt happening here on the upper bulbar area. I saw that there was, why did I say it? Because we need to, I'm stressing again, even if you don't feel that there's anything on the cornea, you need to examine every part of the eye surface. So I saw, and there was also a melt, and there was involvement of the limbus 9 to 10 clock hours inferiorly. I took him up for AMG. This is the first, I think this is first 48 hours when I started to see that the AMG started to disintegrate fast. Yes, in children, it does go in a fast mode. Normally, the AMG stays on an adult surface for at least 2 weeks. But in children, it starts to come to pieces within a week. But this was happening too fast. So I took him up again, and I was happy with the outcome. This is at 2 weeks post-op. The eye was quiet. There was a symplepharon, but at least the melt has been taken care. And then what was the pressing need after this was this. This is a partial limbal stem cell loss, which we can see. And since he is a 5-year-old boy, this was a risk for causing the eye to go into amblyopia. So then again, I took up the child for a conjunctival autograft with a small piece of tissue from the same eye, because the parents did not want to take it from the other eye. So I had to take it from this eye, but I took it from somewhere very far, and I dissected this whole area, and I put in a conjunctival autograft in this area. So this is how the child looks 1 year down the line now, 1 year or 18 months, I should say. So he's happy. He has a vision of 612. Yes, there is a sort of amblyopia, but the child is not keen for a contact lens. I wanted to do a contact lens trial so that his vision potential improves as good as the other eye. So now AMG. Why is it important? AMG is important because it promotes epithelialization. It acts as an anti-inflammatory and also as an anti-angiogenic. and also suppresses the inflammatory infiltration. So steroids, why is it important? Because what all we have spoken about is what I'm stressing on now. Steroids has no adverse effect on the epithelial wound healing. Please remember this point. We get a lot of cases where people think that because of a total epithelial defect, like the one I showed earlier, there was no steroids which was started. No, in the first 7 to 10 days, you can start steroids and you must start steroids. It helps in the healing, it helps in the repair, and it also prevents further inflammation happening. So according to the grade is how much frequency you have to start the steroids. In a grade 5, like what we saw, we have to do it hourly. In the second case where we saw, we can start it at maybe 4 to 6 times because it was not involving the cornea as much as it is involving the sclera, the conjunctiva. So the mainstay of therapy, I must say, is corticosteroids. I'm highlighting it because this has to be done. Please, please, anywhere you see this kind of a case, don't hesitate if it is in the acute phase. In after 7 days, there is honestly no role of steroids. Start tapering when the epithelium starts healing. That is important. So do stain and see if it starts healing, you have to start tapering. Stop if thinning or melting is seen. So you have to, it's like a double-edged sword. Corticosteroids is, we have to balance it. So if you see that this is too much or there is more risks, please do send the patient where it can be handled. Intermediate or early phase, this is what I did for the child. I did the amniotic tenons transplantations. I did not have to do tissue adhesives, but yes, if you have a perforation, like if this was left, we may have to do a gluing and then do AMJ then. But tissue adhesives is used for the cornea. And then if required, then we may have to do for patch grafts. Management of chronic phases, goals, like I said, we have to be cosmetically improve this kind of an eye. Surface stabilization is what we call it. Ocular surface rehabilitation. And if required, we have to do a keratoplasty, or in very severe cases, one-eye cases, we have to think of keratoprosthesis. I will not be touching upon this because it's a very wide topic. Now coming to a very basic and a very important topic is SLET, which is the most important for management of chronic cases. You have, it's called a simple limbal epithelial transplantation. It's a single stage procedure, very easily affordable and uses minimal donor tissue. But the patient has to, the eye has to be quiet for at least 4 to 6 months before you can think of this, before you can send it across or think of doing it. It has to be in a quiet, uninflamed eye. So this is a patient of mine, the third case. This came in a chronic phase, yeah. But it has not gone into a chronic phase yet because of the non-healing epithelial defect with a punched out look right at this 3 o'clock position. There was a huge epithelial defect which was covering almost half of the cornea, 12 to 6:30, and a punched out non-healing defect. We did an amniotic transplantation, and I did it as a inlay, onlay with also patching, and we got a very quiet eye within the next 6 weeks. And the patient was happy, and over this we gave him a scleral contact lens where the patient was very happy and we did not have to touch the eye further. This is another case of mine which we recently did. This is a patient with 15 years of Juna injury. He has kept, so you can see this one small white particle, thick particle right in the center of cornea. This is a Juna, or we call it as lime. This lime particle has not been touched by anybody. He has gone to multiple places. Nobody has taken this lime out of his eye. Because of this lime inside, there has always been a lot of inflammation going on, lot of this kind of vascular tissue. There is symblepharon. His eye from top used to not move. There was a mechanical ptosis because this was pulling it. This kind of tissue pulls the lid towards the cornea. So we needed to take him up. We explained the prognosis. He came to me after a year of explaining. And finally, we took him up and we did a DALC along with a SLET. This is 4 months post-operative picture. Now coming to why SLET, what is it? This is how SLET looks. I would come to the videos. But what is the source of the stem cells? This is a small video which I will show about a chronic phase which I did, which I operated almost, this has been 3-4 years back. So this is a total conjunctivalization chronic phase. I'm checking the freeness of the eye, if it's okay. Do I need to put any kind of sutures to retract for my, for my view? But it was freely mobile. Now what I'm doing is I'm going 2 mm away from the limbus, dissecting 360-degree conjunctival tissue along with the tenoids. We have to make the area bare. It has to be completely bare. This is a very short video, but honestly it takes a lot of patience and a lot of time to do this. You have to do it. There's a plenty of bleeding. You have to keep wiping. You have to have a good assistant. And I'm cleaning it out, so you can see that we need to try and take it out in one piece. This is the whole fibrotic tissue which was covering the cornea. You can see that it has cleared up. And I'll just quickly go further. We dissect it out carefully. Please be careful that we do not want to perforate. We have to minimally take it out, never wanting to clear the cornea to its good clarity. Otherwise, we'll be causing a lot of harm more than helping out. Now I'm clearing out the fornices. I'm clearing it out from all the adhesions, and I'm checking it out whether everything is okay. So this is the pannus. We call this as pannus or conjunctivalization that we saw. This was an excision of that. Coming to the next part, this is the second part where I take the amniotic membrane. So this is how it looks, and I have taken it. We take the surface downwards and we stick it. So we have to place a glue. I'll show you that. So we are taking the amniotic graft, we flatten it out in all sides so that it is pressed. The excess of the graft is cut out. But in this case, everything was taken out. The whole 2 mm of the amniotic graft was taken out. And we retract a part of it and we put in the glue and we put it back, fibrin glue. We do the same thing with the other side. We pick it up, clear it out everywhere. And there is a glue called as a fibrin glue. So we put that has 2 parts. So it attaches the amniotic transplant layer to the corneal surface and the ocular surface. This is the glue. I'll quickly go through this. And now I'm tucking it in. It's very important to tuck in the tissue so that the glue and the surface and the graft adhere together. And you have to be very patient because this has to stick. These 2 instruments are very, very important. And now whatever is remaining, I cut out, and also the excess glue. So there is going to be a glue which comes out. We have to know that the glue also has to be removed. Now coming to the second step where we need to take the transplants. So you see this bottom picture, I have shown you a cadaveric eye because this patient was a one-eyed patient. So I took it from a cadaver, the eyes which are donated by people who die. So they have donated, and we have used a central cornea for another case. And now I am taking these limbal stem cells. But if you have a patient who has the other eye which is all right, completely normal, this is how the limbal stem cells look. And you need to take a 2 mm by 2 mm piece from here. So I'll quickly come to this. The same procedure is done even on this area. You cut out a thin layer, and because we have a lot of tissue, I've taken all around. I've taken this side as well as that side. So this is how we dissect it out. I've taken that piece, and the other side again I turn it. So okay, I've already taken the 2 pieces. So and then we cut them out into small pieces bit by bit. I'm doing it now. Okay, so this is the second half which I am taking and dissect it out. So I have 2 good thick areas, and now I have taken it. I'm checking it for how much quantity I have, and then we need to cut out very small explants. They're called as explants because they are donor explants. The small 1 by 1, one piece, you patiently do it over the corneal surface. You have the amniotic graft already in place. So we are doing it over the amniotic graft. So I'll come to this part where I have cut out all the pieces. And next is, this is how it goes. So I place them. So we have to avoid the central area. Never put the explants in the central area because it can cause scarring and then the vision would be hampered. So always put them in a circumferential. You can make 2 rows if you have tissues sufficient, or 3 rows. Like here, I have done almost 2.5 rows. So we put glue on each of them, and then once they are, we wait for an probably minute or two, and we check all the tissues whether, and we also need to count because we should not misplace any of them. I'm sorry. So this is the final outcome of it. This is how it looks in the end. And we place a bandage contact lens on top. So this is how it started in, this is a very popular article, very famous and very much, read by all of us. You can go back and read it. And this is from where we all started doing this surgeries. So what is SLET? SLET is why we do these kind of cases into these. This is why it's called SLET, simple. Because we can easily take it from the other eye. We don't need to culture it. And even if we have to take it from a cadaver, we don't need to culture it. That's why it's a limbal epithelial transplantation. Take home, summarizing, thorough saline irrigation of the whole surface must be performed immediately. Topical steroids must be started. Management, either medical or surgical, must be aggressive. Continuous assessment, because the severity of the chemical injury changes once the treatment starts. So if you're giving a medical treatment on 24 hours, you have to review it in the next 24 hours or 48 hours to see what grade has it come to. It needs to improve. If you have a grade 3, it has to come down to a grade 2, or at least not become worse, which means your plan is going correctly. So continuous assessment is very important. And treatment must be tailored for every case and not taken as a blanket therapy. And close follow-up is mandatory. Thank you.
All right. Thank you so much, Dr. Surabhi, for such a wonderful session. So lots of information going through this presentation. I feel like most of the audience has taken lots of knowledge from here. So I'm going to pick up some of the question. So let me go into the chat section. All right. So I request all of you, if you have any questions, kindly drop on the comment section. Dr. Surabhi will be happy to answer your question. Doctor, till now, we didn't have any question. So maybe participants are typing on. So if you like to review, or if you want to share any notes to our participants.
So my main thing to present on this topic was to make people aware, because we're all in the same fraternity. I request everyone, be it a student or be it an optometrist or be it any eye care helper, any eye care health worker, we must know that this topic can be easily managed by us, this condition, because I have to repeatedly stress the saline wash is very easy. Topical steroids can be easily prescribed. You just need to grade it, and you can actually color code it, document it, or take photos, whichever way is easy for you. But only if it is beyond grade 3 would be when you would want to refer it, if not being able to take care of it.
Okay, thank you so much, Doctor. So I can see the comment from the Bimal Paurel sir. He is the president of Nepal Ophthalmic Society. So thank you so much, sir. He's saying that it's excellent presentation. Once again, thank you so much, sir. And I'm going to give a short announcement here. All right, let me share the screen. Okay. So we are going to have a symposium on myopia. So Mero Eye is doing coordination with the Brian Holden Vision Institute from the Australia. So this is going on the July 3rd. this July 3rd on Saturday, 2021. So I would like to request all the participants kindly stay on. We'll be update everything for you, and you also, if you have get regularly Gmail from our system, you'll be get the Gmail, or you can also visit our official page for the more information. So let me check if we have got any question. All right. So, doctor, I guess participants get pretty much clear about your topic. So we weren't getting any question. All right. So, doctor, before ending the today's session, if you have a good notes to share with us.
They're either clear or they're confused.
Maybe clear.
No. Thank you very much. And if required, I'm always available on the phone or else email. Any queries, any patient to be discussed, I'm always there. So you have all my, contact details.
Yes.
So you can please feel free to extend it to whoever requires any doubts to be cleared.
Yes, ma'am. So most of the time, these videos are in the YouTube. So after the few more times, participants also get commented over there. So I definitely share this link to you. Once again, thank you so much, Dr. Surabhi, for your time. And I feel very honored. Our team feels so honored for your presence.
Thank you so much.
Thank you so much, ma'am.
Thank you so much.
So herewith, I would like to request all the participants to stay safe, stay connected. We will be touching you on the next session. Thank you so much.